This episode of the Build Beyond podcast is perfect for you if you've been struggling with pain or injury and nothing seems to be working. Now I'm excited to welcome back Philipp. Joe's a chiropractor who practices in Detroit. He enjoys working with athletes, particularly in sports such as golf, football, and baseball. In this episode, Joe and I discuss the concept of learning from pain and injury as a path to getting the long-term results that you want. Now, people often seek chiropractic care with the idea that we will be able to remove their pain. People want to be fixed. And they often feel like broken down cars that need a tune-up. Now, chiropractors tend to have a fixing reflex because we're trained to put our hands on people and make them feel better. That's what people expect from us, and that's what we like to do. So this seems like a perfect relationship. You have people who want to be fixed, and they work with chiropractors who like fixing people. The problem is that this type of relationship typically only yields short-term results. And then in the pursuit of long-term results, many people become stuck in a never-ending loop of routine chiropractic adjustments simply to feel normal. This is actually a negative perception of the chiropractic profession. Many people who could benefit from seeing a chiropractor are hesitant because they don't want to feel like they need to get adjusted routinely for the rest of their lives just to feel normal. They don't want to get stuck in that never-ending treatment loop. But is this the best that we can offer as chiropractors? I don't think so. And is this the best that you can hope for as a person in pain? Not even close. So if you're still listening, then I believe something in this episode will be of value to you. You have better options than just getting your back cracked. I hope you enjoy this conversation. So I've had the idea for this episode for a while. There's been a lot of different ways that I've been thinking about approaching it. Mostly I guess what I want to avoid is acting like I'm lecturing other healthcare providers on how to be good healthcare providers. So more so I'm trying to talk to patients or potential patients or people out there who are confused and give them information. And so I came across randomly, it was probably a week or two ago, an Instagram reel, and the title of it was Never Waste Your Suffering. And the guy was talking about suffering in general. I think he was talking more about like stress and anxiety and things like that. But basically how you can learn from it, or you can just let it crush you. And I think this is coming more from like the mental health perspective. But it ties in so well with what I wanted to talk about, because when people come to see us as chiropractors or any healthcare provider, but I think chiropractors are maybe a unique in a way. And I guess I'll throw a physical therapist in there. People come and they're in pain and they want help. And they want us to take their pain away. They want us to fix them. And we have the ability to do hands-on care. So there's this perception that something is messed up or out of place or needs to be changed with our hands. And then we as healthcare providers have this like fixing reflex where we have skills and we've been trained to do certain things and we want to go help fix people. So we would go in with our hands and do things, and then we would tell them like, hey, prescribe them. You need to do this, this, and this. So it's this very like transactional relationship, where someone comes in, they have pain, they feel broken, and they essentially treat us like a mechanic. That's kind of, I think, a good analogy. Well, I'm broken, I need a tune-up, I'm going to go in and get fixed. And then it pairs nicely with us because we have this fixing reflex because we have skills and we have education and we have a facility and we like, yes, we can do this for you. And the patient comes in, so we fix them like a car and then they leave. And I think this idea of never wasting your suffering is interesting because it kind of gets at this very specific feeling that I've been having for a long time of where is that line drawn, and it's probably different with every individual person, where we should do less. You know what I mean? Like, just because we can do things to someone, if we do too much, are we creating a dependency and not letting them learn how to help themselves? Because maybe you've had this experience also, but people with chronic pain, so it's like they've had a certain pain for years. And it's not always there, but it's kind of always there. And it can get worse at times. And these people have been to chiropractors. Usually they've been to physical therapists. They've taken medication. Some of them have had injections. Some people have even had surgery. And they still have this chronic pain. And so they come in and they want someone to fix them. But then there's that realization that, at least that I have, that, well, that pain might always be there. They might not be able to fix that in the way that they want. So by going in and trying to fix them and take away their pain, are we actually wasting their suffering and stealing an opportunity for them to get better? And I think that, for me, for a while, has been this internal battle with each individual person. Is this someone who can learn from this suffering? They just need they need guidance. Or is this someone who actually needs to be fixed, I guess? And like, how do you draw that line? I don't know. How do you wrestle with that question of, like, if I do too much, I might actually be holding this person back?
Yeah, it's a good question. Really good question. I think it starts with, like, for me, when I first meet with patients, right, I want to know what is their goal, and I have a goal for them once I find out what their pain is. And then I want to know what's their goal. And, there's some patients that come in and go, yeah, I have low back pain, let's say. And I want you to take care of me. I'm not going to do anything at home. I just want you to fix it. I want to be pain-free for right now. If it comes back, it comes back. So be it. But I don't have time to do things at home. It's just going to be working with you. And then there's some people whose goal is more than that. Like, come in, help me with my low back pain, give me some tools that I can do. The second you give me those tools, I'm going to go home and I'm going to work at those. I'm going to do everything you prescribe for me. I don't ever want this to come back. So I think a lot of times that's what I love about also being cash-based, is you can customize goals for different people, where, like, for certain people with, say, low back pain, you don't have to just treat the symptom of the low back pain. You can help them as a whole.
Yeah.
Versus, a lot of times if you take insurance, you're just solely focused on that area of the low back. And maybe that is their cause for pain, but it also very well could not be their cause for pain. But I really like the freedom of that with the relationship with the patient on figuring out what they want. I have a goal for you. Does this goal align with your goal? Can we work together to reach an outcome?
If someone comes to you and they're like, I'm not going to do anything on my own, I just want to come in and get my back cracked, do you still work with them?
Yeah, I do. I usually draw it out for them, like, okay, if I do these things, whatever it may be, say it's just like some passive care modalities, whatever it might be, odds are pain will most likely come back down the road. This is just going to be a temporary Band-Aid fix for you. If you don't ever want this to come back, we have to do this, whatever it might be, depending on what the patient's dealing with. And sometimes patients are like, okay, yeah, great. And I've had it at times where, the patient at first is like, no, I just want the simple Band-Aid fix. And then the pain comes back. And then they come back in, and then I give them the Band-Aid fix, say, we got to move on and do some more visits or whatever it might be, or transfer your passive care into this. No, I just want the quick care. Well, okay. And then usually after the third time, it's like, okay, I'm getting pretty tired of this pain. Like, what was that you were talking about? Which I haven't really seen it as much like how you were talking about with chronic pain. If someone's dealing with it for a long time, usually they're just exhausted of the pain. They want it to be gone. If someone comes in with something new, you tend to see that a little bit more of like, yeah, let's go this route. Let's just see how it feels. And then the pain, if it comes back, then they're like, maybe I changed my mind. I want to go. I don't want this pain to ever come back. Let's go the other route.
Yeah, we're a little different then. If someone just wants to get their back cracked, they just want simple pain management, I don't work with them.
Mm-hmm.
Because there's, a lot of other options in pretty much every area where you can go get cheap. I mean, you can use your insurance. An adjustment's relatively cheap, usually. So I don't even have a rate for those types of care. But also, I have a lot of people come to me asking for that, and then I just be like, "Well," I ask them, "What are you dealing with?" And then when we get into that conversation, usually people want more.
Yep. Well, and for me, I still do an hour session.
Yeah.
So I still cover everything within my session. I guess I'm more just talking about, and I didn't really clarify that. When they're done with my session, I say, okay, if you can't come in for another week, I need you to do these things over the course of a week.
Yeah.
If they don't do that, it's hard to progress forward within the care plan. So with me personally, when they come in, I still do the full treatment. So if it's an adjustment or a passive care modality mixed in with active care, mixed in with whatever it might be, I still do my full thing in connection to the goal that I want for them. But a lot of times that goal that I want for them involves them doing some additional work. If, like, I have one patient, she can only come like once every 10 days just based off of her work schedule. So it's hard to progress if she's not adding in some stuff at home, I guess was more what.
Yeah, there are a couple kinds of patients where I think, well, so for example, like migraine patients. There are people with migraines who are just dealing with it. They have their own routine, and sometimes coming in and just getting pain management treatment is useful for that. They might like getting adjusted or like soft tissue therapy and things like that. And they're just really looking for someone to play a role in a larger plan that they already have. I've seen something similar with people who have had physical trauma. So let's just take like a military veteran who's been blown up and shot. Someone who's had orthopedic surgery, they've got screws, pins put in, permanent nerve damage. A lot of times these people they're already doing all the other stuff. They're trying to exercise, they're eating well, they take medication, they do all these different things, and they're just looking for, they're not looking for someone to take away their pain. They're very well aware that the pain's never going to completely go away, and they're just looking for someone to play a small role in this larger plan that they already have. But I think those patients, at least for me, are few and far between. And I think there's this interesting thing, and a lot of people don't think about it. So if you think about pain or injury, I love the idea that pain and injury can be a request for change. There's something going on, even if it's like a non-contact ACL tear. So some soccer player, she blows out her knee. Well, why? She's done that 10,000 times, never torn an ACL before. Didn't get hit, turf didn't give out, knee just gave out. Well, why is a good question to ask, right? We can go in there and surgeon can repair it. We can do all the rehab, but why did it happen in the first place? So you want to look at, what is the body, like what's the request for change there? Is it nutrition? Is it strength and conditioning? Is she burning the candle at both ends? Is it stress? Is it a skill level? Is it footwear? What can we actually start to nail down what needs to change in order to reduce the risk of this happening again? And I think for people with chronic pain, usually when you go through everything that with them that can add up to pain, there's a lot of boxes that are unchecked. Most people are not meeting physical activity guidelines. They're not walking enough. Their diet could use work. They're carrying extra body weight, which in and of itself probably isn't contributing to chronic pain, but the lifestyle that's leading up to that which is probably largely nutrition based. A lot of people are carrying way too much stress and anxiety. There might be relationship issues. There are just so many things going on. Sleep's another one, chronically bad sleep. So if you've got someone who comes in and they're like, I've got this chronic pain and I'm sick of it. I've been to a lot of different people and no one's been able to fix me. Well, we can, and they want someone like us to come in and have the magic touch, or to have like the special rehab program or the modality that's going to fix them. A lot of times I feel like I'm looking at them more about like thinking, okay, well, what can we learn from this? And this isn't usually a conversation that people want to have, but when someone comes and they say, well, I want you to help me, I don't think a lot of times they realize what they're asking. You know what I mean? Where they're saying, because in their mind, I want you to help me. I want you to do something to me. And I'm sitting there thinking, well, a lot of people have already done stuff to you. And I'm not necessarily going to do anything better than what they did. But has anyone ever talked to you about these other things? And usually the answer is no. And so if we just pause and we think like, well, what can we learn? I don't know if you've ever asked a patient that, but they look at me like I've got like a horn growing out of my forehead, because it's just not what they expect to hear. But usually when we start to have these conversations and I start to let them know like, hey, do you know like depression and stress and anxiety are associated with low back pain? Do you have any of that going on? Usually there's something going on for a lot of people. Or how's your sleep? No, like, how's it really? And we get into these things and people start to realize like, okay, I've got a lot of things in my life that have been going a certain direction for a long period of time that are probably contributing to this. So then it's weird, because as now I'm talking about this and we're going down this path, it's almost more like therapy, like mental health therapy in a way, because we're just talking a lot, where they're talking and I'm just kind of probing. But this idea of asking someone, what can you learn? So you've got this request for change. What could that request be? And when they, like the person in pain starts to list off all the things in their life that could be contributing, and then they can start to prioritize, and then they get to pick where they want to start. Well, now I think we're adding some value that no one else has added. And then on top of that, if you throw in like the hands-on care and the rehab, I feel like that stuff ends up just being the icing on the cake. It's not the cake itself, where that's what people think. They're coming in, I want this is what I want. And it's like, no, you're asking for one thing, like you want this result and you want me to do it this way, but they don't match up usually. We can do those things that you want, but not exclusively. They're small bit pieces of the larger puzzle. And that's what it's almost, I feel in a way with a lot of people, if I do too much, that I'm stealing from them. I'm stealing an opportunity. And I think the best analogy that I have, when I started working at the health center a couple years ago, we have a lot of mental health counselors there. So I kind of just integrated into their crew, and they had a book club going at the time, and they were starting a book on eating disorders. And I know relatively little about eating disorders. I know how to like tell if an athlete has signs and symptoms of something that could be an eating disorder, but that's pretty much it. So I got to go through this book, and we had some counselors who specialize in eating disorders. One of them had an eating disorder. And there's a couple of things that I think were really interesting that stuck with me, and I've thought about a lot. So eating disorder is similar to an addiction in a way, but very different in a very important way. So if you're going to AA and you're recovering from addiction, you are never recovered. You're always in recovery, because you can live without alcohol. You can live without drugs. And so you're never going to be able to go back to that lifestyle. But you can't live without food. So it's a very important distinction that they make is when you're recovering from an eating disorder, you have to be recovered, ED. You cannot be recovering your whole life. And what a great analogy or the similarities between chronic pain. Like we want to get you to a point where you are recovered, because we're not going to be able to replace your spine. And even if we replace your knees, is the pain really going to go away necessarily? Maybe, maybe not. And so when counselors work with people who have eating disorders, doing anything for them, from what I remember from the book, is actually seen as a negative. So if someone comes in and you're helping them in this office setting for an hour, they have to go out and live their life with food, and you're not going to be there. So anything you do to them or do for them is stealing from them. They need to fail and recover and work through this. And it's this whole process for people with disordered eating patterns where they actually have to do 100% of it. And the therapist is truly just this guide. And what an incredible tool, I feel like, or ability as a healthcare provider to just take people who are lost and are suffering and have this chronic problem that could potentially kill them and say, like, I'm not going to do anything for you, but I will walk with you on the journey. And I think it's this interesting thing because with counseling, at least with mental health, it seems like if a counselor does too much in any regard, that's seen as creating a dependency. It's actually it seems to be, from the outside looking in, that would be a very negative thing for a counselor to get too involved and do too much. But what other healthcare provider, what other profession is that? It's almost the opposite. Like, we're trained to do so much and to fix people and have this fixing reflex. I just think it's interesting, and I wonder in a lot of ways, for people with chronic conditions, if they're not going to go get surgery and they're not going to go have like someone actually go in and mechanically change them, if we do too much for them and too much to them, ultimately, are we just slowing their progress? You know, like their full expression of what they could be is so high, and by them coming in and me rubbing their muscles or doing things for them and babying them in a way, am I just holding them back and creating a dependency because they feel like they have to need me? I don't know if this is stuff you thought about. This was, like, as I said, this was an episode that I wanted to do for a long time, but I was thinking about ways to verbalize this because this is just like things that go on in my head. And this was going to be a solo episode. You're going to be in town. So what this was just going to be is me talking for like an hour, just basically like working through things verbally. But that's kind of like, I have a bunch of notes, but they're just kind of, I don't know. It's just kind of chicken scratch, like train of thought kind of things.
I have a good example for you. So you were talking about headaches. I'm actually curious how you would respond with this as well. But earlier on there, you were talking about headaches a little bit. So my wife and I were at Walmart. Gosh, this might have even been a year ago. It's just so ingrained in my head that I still remember it like a year ago. And there was a couple in front of us at the checkout line. And one of them had said, "Oh my gosh, I have a terrible headache. It's back again." Okay, so instantly they have headaches periodically, right? And it's just a splitting headache. And they were just talking about it it was a longer checkout line, so for probably, over a minute straight. And finally, the person with them goes, "Here, this always helps my headaches." Opens the fridge there at the checkout line, grabs a big old bottle, hands it to him. It's a bottle of Mountain Dew. "Always helps my headaches. Headaches always go away from this."
Yeah.
Okay. And the person that had the headaches goes, same for me. That helps me as well. Not exactly like that, but they're always like, yeah, oh, I agree. Yeah, give me that, right? And so they scan it and they're chugging this Mountain Dew on the way out. So they have headaches periodically. So what I thought of in that moment was, man, if that patient came to me, right, and how you're talking, like they have headaches, we can manipulate whatever it might be. Maybe on the first visit when we ask them, is there anything else that you're doing? No. I mean, I eat fairly normal. Like I have, chicken and rice and some vegetables or whatever it might be. Do they add that they chugged a whole thing of Mountain Dew, right? Maybe they don't. So that's information you would never know. But then also on the contrary, if that's something they're so used to and they are fully convinced that every time they chug that Mountain Dew, their headache goes away. How do you as a clinician go, maybe this isn't right? Maybe you know what I mean? Like that's a kind of a difficult thing to go back and forth with, where it's something so simple, right? Like I personally wouldn't do that if I have a headache. But I just am kind of curious for you, like if with a habit like that, and maybe it's not Mountain Dew, whatever it might be, they have to drink a large thing of coffee or who knows? How do you manage where someone comes into you and they're convinced something like that is what relieves their headaches, but maybe it is, maybe it's not. I mean, you know what I mean?
Well, I don't focus on the symptoms. So I'll let someone tell me all about their headaches, for example. And then I basically have 4 things that I need to know from them. And one of them, the first one is, how is this affecting your life? What can't you do because of your headaches? Or what is not fun anymore? Or what impact is it having? And why is that important to you? And we could spend a lot of time just on this one. Sometimes this is the only thing we talk about. So then I shift away from the headaches. It's like, okay, well, I want to focus on the things that are important to you. So it might be like, well, I get these headaches and they're always later in the day, and then I can't enjoy hanging out with my kids, or I can't enjoy doing different things. So and headaches are a tough one because that's a tough case anyway, because there's so many things that it could be a lot of different things, but I think it's maybe a good one for this discussion because I want to know how it's affecting you and why that stuff's important to you. And then I want to know what they think is going on. And I kind of don't let people skate on these things, if they're like, oh, it's not really affecting me at all. I'm like, why are you here?
Right. Yeah,
why are you spending all this time and money? There's a reason why you're here. And I want to know. And then we talk about what they think is going on. And people know their bodies better than anybody else. And I think a lot of times they don't trust their intuition. Where I think, I think it's especially true with women where they're like, I don't know, the thing they don't want to say, it's silly, but I think this might have something to do with it. I should keep stats, but I would say 99% of the time, that's part of it. And they don't want, you know what I mean? And they're second guessing themselves for different reasons. And so if I know what it's affecting and why that's important to them, and I have an understanding of what they think is going on, then I can start to ask other questions of like, okay, well, what have you done in the past? Did it work? What'd you love about it and what'd you hate about it? And what are your goals? So if they're just like, I just want to get out of pain. It's like, no, if that truly is it, then I'm not a good healthcare provider for them. So I'm probably going to send them to just another chiropractor to get adjusted because I don't want to spend my time doing that. I want to work on things, but it's never that. There's usually some type of goal. And then why is that goal important to you? And what's your timeline? I want to know all these things. And then why now? Like, why'd you book this appointment now? how are you hoping that I can help you? Specifically, tell me what you want, you know? And if we could hit an absolute home run with this, what would that look like? I think once people, so again, like I haven't really talked about their headache or the Mountain Dew at this point. I'm talking about everything else. And usually in that conversation, something like Mountain Dew is going to come out. You know, they're going to, they're going to be like, oh, what have you done in the past? Well, I drink Mountain Dew. Oh, fascinating. You know what I mean? Can we talk more about your nutrition? What else, you know, what do you think makes it worse? Is there something, or is it something that's just like they don't eat all day, so they're just really low sugar, so just putting sugar in, you know what I mean? If it's like, if that's it, could we eat an apple instead and see what happens, or some grapes? You know what I mean? Like, can we just swap out the source of the sugar, and then maybe we can just flip that completely? I don't know. I think if you just, and I do the same thing with low back pain, with knee pain, things like that. Like, I want to hear all about your pain. Tell me all about it. Once they're like, yeah, I've told you everything, we usually don't talk about it again until treatment. I mean, I think that's ultimately, there's things I want to do in the office to help them. But
and
yeah.
I don't know if with you this happens, but I've noticed a trend of you get more and more details out on like the second and third visit. So after they go through the first visit with you, like usually at the end, I'll ask the question, is there anything else that you possibly could think of that could connect to whatever is causing the pain, right? So let's say back to the headaches. Is there anything else like that you do maybe a couple hours before that leads to a headache, anything at all? And if they say no, okay, like I have everything I need down. And usually if you listen carefully on the second or third visit, it'll just be in like normal conversation, right? Like, so how was your weekend? Oh, it was fun. We had hot dogs and pop for lunch. Another terrible headache at 3:00 though. Oh, okay. Like, what was your nutrition like prior to that? You know, and maybe you'll ask them about nutrition. They say, yeah, no, I eat pretty good on the first visit, you know. But I have had that where like on the second or third visit, I think they just get a little more comfortable with this scenario and stuff, but you can just pick little things up on just normal storytelling where then you can ask those follow-ups like, oh, this is interesting.
Yeah, I think a lot of people, when I ask people what they think is going on, what they think they need, I think you get some really interesting stuff. So, you know, I would never tell someone to not Google their symptoms, because I think doing your own research is a good thing. But they just have to realize that there's so much information out there and so much is not tailored to them. So I want to know, like, what do you think is going on? You know, because at least with chiropractic, a lot of times people will be like, well, I think my spine's out of alignment. And I think anyone that's listened to my podcast enough would know that I don't believe that we correct spinal alignment. And it's actually not so much of a belief anymore. It's like we have no evidence to show that we do that. So if that rubs anyone the wrong way, you know, I'm still an open invitation to have someone on who wants to defend that. But for those listeners out there like, wait a minute, I get adjusted. My chiropractor says that they're realigning my spine. If we could put our hands on someone and just smooth the bones and permanently reposition them, then anytime you slip or fall, you die. You know what I mean? Like, that's just so unstable. So I think a lot of people have that in their mind though. And so I don't correct them right there, but they're like, oh, I think I'm in this pain because I haven't been adjusted in a while and I'm probably out of alignment. Well, that lets me know a lot, you know, and it's not that I wouldn't work with that person or I would try and correct them right there, but I'm going to move them in other directions. Especially, you know, if someone's like, well, I think my spine comes out of alignment. It's like, okay, well, that is some instability to say the least. So adjusting it and creating more movement at a joint that already has too much movement, it's not logical. And usually people will be like, oh yeah, that makes sense. So we would want to create some more stability then if it's too loose, if that's how they feel. So I think usually you can flip that kind of stuff pretty quickly. But to your point, yeah, like if someone's closed off. I don't push too hard, but also I think in a way, and this is the benefit of being a cash-based provider, is that we get to pick who we want to work with. So I don't work with everybody who tries to book an appointment with me, because if we're not on the same page, everyone's just going to be frustrated. And I think people appreciate that. But the people who are willing to come back for more, you know what I mean, to do a plan of care, I think you will get a ton of that information later on. And people will really start to open up and start to realize that these things are important. But I just still wrestle with the idea of if I do too much for someone, they tell me what their goals are. And usually the goal is, I don't want to be relying on healthcare providers. I don't want this pain to affect the fun and important stuff. I have these goals. I want to be able to do this, 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 and this. And usually I just feel like, okay, if I could go in right now and take away their pain with my hands, am I stealing some motivation? You know what I mean? Am I stealing an opportunity for them to work through this? It's like if you go in and adjust someone, and let's say they're in 7 out of 10 pain, and you feel like you could take them down to 2 out of 10 pain real quick. You could do that. But if you've got an hour with them, you could also spend that hour working with them to see if they could get themselves down to 2 out of 10 pain. Okay. And if they can't, and they can only get themselves down to 4 out of 10 pain, that's still a win. They went from 7 to 4 without you putting your hands on them. I mean, could we keep going? Could it, you know what I mean? Are they now are they on that path to being recovered in a way where they're learning, where if I just go in and make them feel too comfortable too quickly, is that actually a negative thing? And I think that there are scenarios where, if you're in 10 out of 10 pain and you go to the ER, you don't want a physician to be like, how do you feel about your relation? You know what I mean? Like,
what'd you eat?
Yeah. No,
Yeah.
Give me drugs
Yep.
and an injection. And, this is the worst pain I've ever felt. I totally get that. There are definitely times when healthcare providers should just go in and manage pain. I think if I was working with like a cop on a long-term plan and he couldn't turn his head to the left for whatever reason, and he had to go do a long shift, you know what I mean? And he couldn't drive his squad car and couldn't do his job, then yeah, if I can put my hands on him and increase range of motion and decrease pain, get him through that shift, obviously I would totally do that for him. But that would be a one-off. It's not something that I personally would or professionally would want to work with on a routine basis, because I've worked in those clinics. The last clinic I worked at, we had 5-minute appointments and they double booked. So during busy hours, 2.5 minutes, that was the norm. So every 2.5 minutes I was in another room. Computer was logged in by a chiropractic assistant. I was adjusting people out the door. And all of these people were coming in believing that like this was a long-term solution when it was really just this quick fix kind of thing. So I think there's this misconception too, where people feel like, oh, I've got this chronic pain, someone can go fix me. I can just go get some hands-on therapy or some quick stretches or things like that, and it's just going to go away. And sometimes it does. I'm not going to say that it never does, but that's usually if it does, like, I don't see that person, So anyone who's still listening to this episode is someone or knows someone it hasn't worked, which I think is more of the norm. And a lot of times people will go in and they'll get their chiropractic adjustments. They'll do their annual PT. They'll do these things and they won't get the results that they want. And they feel like they're the weird ones. They're like, well, this is supposed to work. I'm so broken that this doesn't work for me. But they don't, I think, see the bigger picture, or they couldn't see the bigger picture and realize that, no, this doesn't work for the vast majority of people. It's not set up to work well. It's really kind of unfortunately set up by insurance companies to help their annual profits, And,
right.
And so I think the whole system is not really set up to help people in the way that they feel like they are going to be helped when they show up, which is a topic for a whole nother series of episodes, I guess. But I think that's the benefit of being a cash-based provider, is that we don't have to think about those things.
And as far as like pain goes, I feel like in the broad space, pain has that perception of being damage, right? And as a clinician, it could be, right? If you tear a muscle or something, there's damage to that area. But pain also can be a huge marker for information, right? And when do people seek help, seek to improve their lifestyle? When something isn't going well. So if there's pain, right? If you're playing a soccer game and you get off the field and you feel 100%, you're not going to go, oh man, I gotta go see someone just to go see someone, But if you play a soccer game and all of a sudden your low back flares up, then that's knowledge for us. Pain doesn't in that sense, if there's no structural damage or anything like that, pain doesn't necessarily mean that there is damage done to them. It just means that in a sense like that whatever they're doing, their body can't handle that load. So how can we help them handle what they're doing? So like, for example, I see it with pitchers a lot of times because I work a lot with athletes, right? And, I think just in my mind, how is it that a pro pitcher can pitch 15 years in the major leagues, throw 100 miles an hour, have no shoulder surgery or anything related to that? And Timmy, who's a junior in college, good athlete, 3 games in is like, yeah, my shoulder's toast. Like there's information there that we need to gather to help them. So with what you're saying, how you can really take advantage and help people that are in pain, because so much information can come in from that, yeah, I can tell Timmy, who's the baseball player, I can get you out of pain with some passive care modalities, simple things. But you're just going to fall right back into this trap. And so if you really want to learn from your pain, and if you want to take all this information in and make it so that you can pitch, maybe you are good enough to play in the major leagues and not have to worry about this. We have to do things to your body to handle that load so that you can go pitch 7 innings with no problem. But what I did want to ask was, so I had like a runner. Runners are interesting to me because if you have like a cross-country runner, right, for example, all they're running is long distance, so they need to be in shape, right? So, but a lot of times long distance running, people will end up with hip pain or knee pain or shin splints or whatever it might be. There's certain things that we can do to help them, but how do you balance like the passive care, quick pain relief versus the longer active care, whatever it might be that you're doing slightly longer? Well, someone like that is in season where they need to stay in shape, but long running causes flare-ups of pain. I just think like those types of questions, especially in sports, I've had people ask that before, and it's interesting in a clinician's perspective, because I think a lot of times in sports, because I've played sports growing up as well, you get a lot of that Band-Aid care while you're in season, right, just to get you through the season. But I've also seen it where the Band-Aid rips 2 games later, right, and then your season's done anyway. So how do you handle that as like a clinician, where if someone's in season, they come to you with pain of some sort, to make the judgment call of, yeah, I can get you running on Friday, or, this may not be the best choice for you?
So this is actually, I don't think this is like a spoiler. If you
Sneak peek.
So the American Chiropractic Board of Sports Physicians, that when you go do the diplomate program, part of the practical exam, there's a rehab station, and it's probably, I don't want to say it's the easiest station, but it's the most straightforward. And part of that is like you actually have to answer this question, and they give you specific references. So if an athlete wants to return to play, and let's say it's an in-season athlete, there's 3 things that you have to look at. One, what tissue do we think is injured? And do we think tissue is injured? And so like you're thinking about it's a pathoanatomical differential diagnosis. And you have to ask yourself the question, is the tissue in an appropriate condition to accept the stress of the sport? And if the answer is no, they're done. You know what I mean? So if it's an ACL tear, unless they're going to play on a torn ACL, like that, so if the answer to that question may answer the whole thing right there. Now, if an athlete, if you think, okay, I think the tissue is in a condition where it could accept the load, and you're thinking about structurally, then you have to ask the functional question, is there adequate strength and conditioning of the system to support the activity? If the answer is no, then they're done. So this would happen maybe, like, let's say if someone actually has surgery, this works quite well as well. I mean, it goes with everything. So if this is a conversation I've actually had with an orthopedic surgeon with an ACL patient. So I went to one of the follow-ups and I was like, look, I need to know if you think the tissue itself structurally is ready to do what I want to do in rehab. And I was talking to him about it. And so he's in that case, he said yes. So you could have a situation where someone goes and gets like an ACL redone and they don't rehab it at all. Well, a year later, that tissue is healthy. It's ready, you know what I mean? But it's not conditioned, So like those two have to line up. The third thing is, what's the risk tolerance of the athlete? So if you've got an 18-year-old who's got her whole athletic career ahead of her, well, she probably doesn't have a very high risk tolerance, because why would you? Why would you push that person? But if you've got an athlete in her early 30s who just qualified for the Olympics and this is her last shot at it, that's a pretty high risk tolerance because her athletic career is done after this. So ultimately, you've got all those 3 things have to line up. Is the tissue structurally in a position where it could accept the stresses? Is the tissue conditioned enough to withstand the stress of the sport? And what's the athlete's risk tolerance? If those 3 are in unison, they can go back in. And they might be Band-Aid. You might have a physician who needs to administer painkillers. You might need athletic trainers to tape them up like crazy. You know what I mean? There may need to be a lot of things to go into that. But if those 3 things line up, then it is what it is. And if they don't line up, then they get pulled. So that's the way I look at it. And a lot of times, the risk tolerance is not as high as what people think. So for athletes, it's like, yeah, this might be your senior season and you're not going to go on after this, but you do have a life after this. So, is this something you really want to risk? And a lot of times the answer is no. And if they do have an athletic career beyond that, it's like, well, it's definitely not worth the risk. So I think more times than not, when I have that conversation with athletes, they elect to not play. The hard thing is that if you don't have control over the situation, so if there are coaches, if there are sport coaches and strength and conditioning coaches and athletic trainers and team physicians,
you're one of a lot.
I'm not. I have no influence over that, and I've run into that several times at the college. And nothing bad, but like where my opinion would be that this athlete would probably need to be pulled, or, we would need to make some big changes to their training schedule. And it's not that people don't want to do it, but a lot of times you just can't accommodate that in college sports. Where in pro sports, you think Tom Brady later in his career was doing the same training sessions as his backup quarterbacks? No way. You know what I mean? Like, so you can't just be like, well, all quarterbacks are treated equal. They are not. They're definitely not.
What is it? LeBron spends like $2 million a year or something like that on his
so
on his body.
You know that, and like if you follow professional soccer and you watch the guys train, it looks like the men are wearing sports bras, and a lot of times they'll wear it in games. There's monitors on there. They track everything for those guys. So because they're, you know, they may pay $100 million. You know, the athlete may be making $20 million a year on an 8-year contract. You know, it's a big investment. So if you've got, you know, Cristiano Ronaldo at 29 years old was definitely not having to do the same regimen as the 19-year-olds on the bench. It just wasn't. It wasn't. That's just not how it is. So every athlete has to realize that they're different. And I think a lot of times when you're dealing with competitive sports that are not professional, there's not that kind of money and they don't have that kind of infrastructure. So they can't treat athletes as individuals. And I think that's the problem that I run into with a lot of athletes, because I don't work with pro athletes, is that, you know, that if they have a unique injury and they have unique needs, there's no infrastructure set up to support that. And I can't be there 24/7, and I can't get their coach to change for them. And there's not, a lot of times there's not 18 assistant coaches, you know what I mean? And all these, they just don't have that kind of support.
Well, and even in like the pro level, those guys, the teams have their trainers and everything, right? But a lot of the guys you see on TV, they have their own guys that go home with them, you know? It's like...
And I would too, because they're not on the payroll of the owner,
right?
You know, and so you want that other opinion.
Yep.
But also, you know, if a pro athlete on a multi-million-dollar contract gets any kind of injury, they're going to get the best care out there. And so it's just a different level. And if I was contracted, I don't think I would as a chiropractor, to work for a professional sports team, because I know what they would want out of me. They would want me to show up at the table and crack backs.
They have their set standard for what they want you to do, because they have
and that's an interesting
program.
thing from the sports chiropractic realm. So if you go through the American Chiropractic Board of Sports Physician, if you go through all of their board certifications, they're never like they acknowledge that there are different roles that we can play. A sports chiro can just go and be part of a crew and you just play that little role. You could be a sideline care. You could be more of a lead where you're kind of quarterbacking and doing different things. But you have to understand your role and your limit of influence. And I think I just would never want to be in that situation where I have no influence. My job is, you know, I'm just a monkey cracking backs, trying to make people feel good. I don't think I'd really want to be in that scenario. But I would want to be more a part of a valued member of a team. And I think when you look at the Olympics, it's different. It seems to be. I've never gone to Olympic Games as a provider, but I know some people who have. And so when the Olympics happens, they'll select a healthcare team for Team USA, and there's usually at least one sports chiro on there. And from the feedback that I've gotten, that those teams are usually of healthcare providers are pretty tight. You know what I mean? Like the physician is listening to the PT and the athletic trainer and the chiropractor, and they're kind of all kind of looking at this complex problem, because you might have hours before that athlete needs to go compete for a medal. So there's not really, I guess egos can't really get in the way in that regard. So I think they cultivate those teams pretty well. And I don't know how that works with pro sports, because I would imagine that an NFL team stocks their healthcare providers with a group of people who are going to keep people on the field. So I don't.
Well,
I don't see too many concussions getting pulled routinely from NFL games.
that was part of my. That was going to be like my second part of this question was because I have a couple fantasy group chats, right? So I thought that they might be interested if they listen to this. But that's a big thing in the NFL right now is one, there's been a lot of injuries that are season-ending injuries this year that we don't quite see as often. It just seems like there's been a lot of Achilles injuries and more non-contact injuries. But then, for example, on the Lions, they've had a couple players where you can tell, obviously we're not seeing them outside of the games, but they'll miss like 2 weeks with injury of some sort. And then they'll play them for a game, and then they'll announce that they're out for the next 2 weeks, and then they'll play for 2 games, and then like I think one of the players now is done for the season. But that was kind of his track record, right? Like played, injury in the third quarter, out the next 2 weeks, came back for a week, out a week, came back for 2 games, out, announced season's over. So, but pro is tough too, like you said, because one, they get a paycheck for when they play, right? I think it's like their in-game paycheck or whatever it's called.
Yeah.
And then also just the amount of money within the NFL, right? Like you want the best players on the field. But just as a clinician standpoint, I think most clinicians, that's one thing in sports that they struggle with. And I know we got a little bit sidetracked here, but from athletic trainers to PTs to whatever it may be, like you said, if you're on the sideline of some of those situations or in the locker rooms, there's a lot of pressure to get, especially in the pros, right, that best player back out on the field. And I think it's the toughest decision for all clinicians to make is, okay, is this bad enough that he's done, or is it bad enough where we can do some quick things to get him back on the field? Is it going to lead to worse things if we put him on the field? And yeah, I mean, I just think it's something that's interesting that happens quite a lot, I think.
Our number one job as healthcare providers on the sideline is to look at the health of the athlete, not the performance of the team. And I think that gets muddied a lot. And the NFL is football is an interesting case study because if football followed its own protocols, you would never end a game. And by that, I mean specifically with concussions. So a concussion, if concussion is a blow to the body or the head that causes some type of neurologic dysfunction. So after impact, any sign or symptom of concussion is a concussion. They don't grade concussions anymore, but obviously some are more severe than others. It's just really hard to grade them. So if the NFL's football protocol is that people don't return to play with concussion, which it is their protocol because that's the international protocol, then every time someone got hit and they felt a little lightheaded,
by definition, right?
They would get pulled. So I don't know that they could actually technically follow concussion protocol and still have the sport. And I think that's the problem. I remember vividly, it was actually the weekend of your bachelor party. We were at Buffalo Wild Wings, I think. I don't remember the game, but it was a quarterback, took a hit and he went into like a decorticate position. So he was laid out like
arms
this.
Extended, yeah.
And I was sitting there thinking like, oh my gosh, that might not even be a concussion. That could be TBI. Like he might have a brain bleed.
Yep.
And I don't think he finished the game, but then they were like, he had played a game previously, I don't know, less than a week before, and they played the clip and he got hit and he got up and he didn't trip. His legs gave out and he stumbled to the ground and then got back up and he got evaluated apparently and then cleared of a concussion. It's criminal. And he got hit hard in the previous game, and the hit that he took in the game where he went stiff was nothing. I mean, like it wasn't even like he barely got hit.
His case it's Tua. Yeah. I think that's who it was.
Yes, it was.
He plays for Miami, but yeah, his case is interesting. They even have you seen that movie Concussion? I think
Yeah, I saw it a long time ago.
the actual doctor that talks about, he even came out and said, this is he's got to stop. Like another hit to the head, and he even may be dealing with something now. But yeah, prime example, right? Like
What? See,
I think it's happened.
He returned to
2 or
play
3 times with him.
the game of that concussion, where he just stumbled.
The first one, right?
So he probably sustained multiple other concussions while he was concussed, and then less than a week later, he gets a light tackle and goes stiff as a board. So it's criminal in a way, and I just feel like maybe even I don't even know, maybe the NFL and football in general just shouldn't even have a concussion rule. It's like, hey, you sign a waiver, you're gonna have a non-traumatic brain injury guaranteed today, and then we're gonna put you back in. I don't know. I feel like it's a weird thing with youth sports or with youth football. I never played, but watching it, I think about like, well, could you just go flag football and really work on the skills? Like, let's get these kids big, strong, fast, and agile, and very skilled at passing, very skilled at catching, very skilled with their hands at defense. You know what I mean? Like, could you work on all of those things that separate decent athletes from elite athletes? The footwork, the visualization, reading the game, understanding the plays, like the skill of the game. And then when they get to a level, that's close enough, like, hey, these guys are going to go to college within the next couple of years, then you start to introduce the full contact aspect of it. I don't know, but I feel like from a little kid perspective, parents who have kids play peewee football, you got to realize that every time he gets his bell rung, that's a concussion. And if they stay in the game, yep, you could end up in that situation where they've got a brain bleed or they've got permanent damage. And, to bring it back on track to the original discussion, it just kind of goes into, it's like, are we doing more harm than good by giving people what they say they want? And I think with a concussion, it's like, it's not even a discussion. One, if I think someone has a mild traumatic brain injury, they can't make an informed decision. They're confused, right? I have to acknowledge the very real possibility that they are not in the right state of mind to give informed consent. So I've got to pull them. And if an angry parent's there, or an AD or a coach wants them to go back in, my job as a healthcare provider would be to protect the health of the player. So concussion is an interesting one, where if you mess it up, they could die or have permanent brain damage. And now if we're talking about just general chronic pain, like a meniscus, or a disc problem in the low back, it's not going to kill them. But if we do too much, are we stealing from them? Are we taking that opportunity? I don't know where, I feel like it's kind of up to the person, but when I've had this conversation with people, I've never had anyone be like, I don't care about my long-term health. I don't care about my long-term goals. I just want pain relief. And maybe I just attract a different type of person, or like that's my reputation, so those people don't come see me. But I think most people want more. And the interesting thing is, like, if you think outside of pain management, you ask people what they want. They want to sleep better. They want to look better. They want less body fat. They want more muscle mass. They want more energy. They want to look younger.
Yeah.
They want a better immune system. They're freaked out about heart disease, cancer, type 2 diabetes, strokes. They don't want Alzheimer's or dementia. You know what I mean? Like, nobody wants this stuff. The crazy thing is that when we ask people, what can you learn from your pain? Let's not waste your suffering. This could be a request for change. And you have them start listing all the changes. And you look at those changes, it's like improved sleep, increasing physical activity, adding in strength training, getting more cardio, taking more steps, improving their relationships, decreasing their stress, working on their diet. Okay. So that's your list. It doesn't really matter where we start. You can pick. You're the patient, you're paying. Like, let's start where you want to start. I don't care. But you pull any one of those levers, what are we doing? We're decreasing your risk for heart disease, type 2 diabetes, cancer, Alzheimer's, dementia. We're boosting your immune system. We're increasing your energy levels. You know what I mean? Like, we're improving your mood. We're improving so many different things by asking these questions and then moving in that direction, not focusing on the pain, but moving in the direction of what's the request for change. And then as we work on those things, the pain gets better. And you get all these other benefits on top of it, and you can have fun with it. But if we don't ask that question or these questions, and we don't shift the focus away from the symptoms to what is the request for change, and we go in the other direction with just pain management, I just feel like I'm stealing. You know what I mean? Like, I feel like I'm taking their money and I'm making them dependent on me. I'm like a mental health provider who's creating a dependency. And I don't know. It makes me feel like I'm not doing my job by doing my job in a weird way.
How do you handle it when, and we've talked about some of this, not on the podcast, but how do you handle it when you go through steps like that? And because I think the hardest thing for a lot of people is actually taking the action, right? Like the physical activity, eating well, all those people, most people at least know, like, yeah, that all makes sense. Getting 9 hours, whatever, 8 hours of sleep, whatever it might be. How do you handle it where there's more of a verbal commitment to it versus a necessary and actionable commitment, if that makes sense, right?
Yeah.
So maybe you have a patient that comes in there like, yeah, I'm going to start doing that. Symptoms still come out. Yeah, I feel like I've been sleeping a little bit better, whatever it might be. The verbal commitment's the easy part, right? You know what I mean? But just as a clinician, how do you feel, or how do you handle that as, maybe a month in, things aren't getting better and there's the verbal commitment, but you're not really seeing much of a.
So it's funny because I do hours at the health center on campus, and my services are free for students and ridiculously cheap for faculty and staff. And there's really no difference in what I do there versus what I do here in my private practice. The results are drastically different. Not because of me, but because of the patient. And I think there's a lot to that. So if there's no buy-in from the patient, why would they? I could give anyone the perfect solution to their problem. That doesn't mean they're going to go do it. You know what I mean? So right. I think financial buy-in is huge for a lot of people. If someone comes in and they spend $3,000, I'm pretty sure I'm going to get results because there's buy-in there. It doesn't have to be a financial buy-in, but we have to know why. There has to be at least an emotional buy-in. And I feel like theoretically, free, easy to access healthcare that's really convenient is good, but it can actually be detrimental if you're trying to make big changes, because there has to be buy-in, because everything in your life is going to be telling you not to do the things that you need to do. And you're just like, why don't I have the discipline? And it's like, well, not very many people have the discipline to make hard changes, but the people who do it usually just have a very strong reason why. And then they can just check themselves and be like, yeah, this comfort-based decision that I want to make is not in the best interest of my long-term goals. So I don't have that problem in private practice. I think specifically because I ask a lot of these questions, and I think I just attract the kind of people who want to work on things. But I heard someone say once, we got to overwhelm a problem with an excellent solution, and I don't think there's a better way to put it. So when someone comes in and they're like, this is what I want, and this is why I want it, and this is the timeline in which I want it, I'm like, okay. I ask them all the questions, and then it's like, all right, based on what you said and everything you're willing to do and what's going to fit in your lifestyle and all your preferences, this is what I think. Do you want to do it or not? And if they want to go on that path, then it's my job to keep them on the path. That's all they're paying me to do, essentially. And actually, I had this conversation with Nikki Ellis a number of years ago. For those who don't know Nikki, she's a pediatrician. And I was
Great pediatrician.
Yeah. And how do I...
Shout out, Dr. Ellis.
Yeah. I was like, how do you deal with it? Because your patients, a lot of them can't speak. They're babies. So you're actually reliant on the parent who isn't dealing with the symptoms. They're dealing with their own things. They have to make the changes. That's tough. Like, well, how do you deal with non-compliant parents or dealing with non-compliant toddlers who aren't going to stop doing or start doing what they need to do? I can't really quote her directly, but the gist of it was that she said, if someone's non-compliant, I feel like it's my fault. I didn't meet them where they were. I gave them a good plan, but it doesn't fit with their lifestyle, or I didn't explain it well. So she said, essentially, I don't think of any patient as non-compliant. I think of the non-compliance as my fault. It's my problem. I didn't do the right thing. And I think that's pretty powerful and pretty accurate. And I think as a healthcare provider, if you start to think that way, everybody wants to get better. And by the nature of them booking an appointment and paying money, they are telling you, I want to get better. If they're not following the plan, that's probably your bad or my bad. You know what I mean? Like, what am I not communicating? Why isn't this working? Why aren't you doing the rehab? Where's the breakdown? Like, we have to ask those questions. And if you ask those questions enough, you'll find a path. There is an excellent solution to every problem. You just have to, but it's not cookie cutter, and it's so unique. Every low back pain patient's probably going to be a little bit different. And so I just think with most people, if they want to get better, my whole job is just to keep them on the path. And so I've got to ask a ton of questions. I've got to check in, and we have to make sure we're moving in the right direction. And I got to make sure that they have patience and they realize that it could be a long path, and that they don't have that I'm addressing their fears and concerns and things like that. But again, nothing there has anything to do with me taking away their pain. It's more of like, let's think about it and try and figure out what your body is saying. Like, why is this happening? And what can you do to make it better? And I don't know. I think a lot of people will be like, oh, well, will you still adjust me? I get that question a lot.
At the very end, yeah.
And the answer is sometimes, nope, and probably not, because I'm not here to steal from you. Like, I'm not here to take that from you. Now, if we're on a great path and we're making the progress, and someone comes in and they're like, I know we're working on a shoulder, but my low back is killing me. Okay, I'll do a quick exam, quick history. I might do some manual therapy, some mobilizations. Maybe I'll even adjust them, because I want to get to that shoulder rehab. You know what I mean? Like, I don't want this, or they're just shoulders super tight. Something's going on. So it's like, okay, we're on the path. I want to stay on the path. This is a way to keep us on the path. I just hate starting the relationship that way, where they're like, well, can't I also get adjusted? And it's like, well, any good experiment, if we have too many independent variables, how do we know if we get the results we want? How do we know what worked? How do we know what's a waste of time? I almost don't want to add that stuff in. So if someone's like, well, I want to start with getting chiropractic adjustments, sometimes I'm just like, well, I'm not a good provider. Then go do that somewhere else. And if it works, you're going to save a ton of money going across the street and a ton of time. If it doesn't work, come back and we'll do something else. And usually people are like, okay, let's start with something else. So it's not that I don't want to do hands-on care, but I would say at this point, hands-on passive therapy for me, I probably do it to less than 10% of my patients. And even those 10%, it's one-offs. Like it's not, it's like increasingly less, because when you look at people's long-term goals, it just doesn't fit in there. And again, I would rather spend the whole hour trying to find a way for you to take yourself from 6 out of 10 pain to 3 out of 10 pain, as opposed to me doing it for you quickly. Because again, I don't know. And this is a big shift in the way I think, and maybe I'll shift back around. But that was the whole purpose of this podcast episode, was that I'd been thinking about a way to address this. And then I saw that video where the guy said, never waste your suffering. And I was like, yeah, that's probably going to be the title of this episode, actually. Never waste your suffering. Because it's true. You can learn, regardless of what it is, you can learn from it. And you can grow, or you can let it just weigh you down. And I feel like, if you got 8 out of 10 pain or worse, go see a physician. Go get some pain meds. An injection. I would. Like if it's that bad. Maybe 9 out of 10, 10 out of 10. That'd send me to the hospital.
It's usually how I ask my 1 through 10 pain.
Yeah,
10 being we're on our way to the ER.
If you're an 8 out of 10 pain, I'd strongly consider it. But a lot of times it's not that bad. And even if it is, I don't know if there are a lot of reasons to just kind of wait it out, I guess. I mean, I guess I have more knowledge, so I wait out pain more than I would recommend a lot of other people do. If you're a 9 out of 10 pain or 10 out of 10 pain, I would go to the ER or see a physician about it. Because why not? Like, take the edge off. Because if someone came to me in 10 out of 10 pain, I'd probably call 911. I probably wouldn't even let them get in the car and drive, if it's that serious, because I don't want to be held responsible if they get in a car accident because they pass out because of the pain or something like that. So I don't know. I feel like I'm just conflicted as a healthcare provider at this point. And I feel like I like being honest with this, because I don't know how many of my patients actually listen to these episodes or prospective patients, but I heard the other day have you ever heard of the Dunning-Kruger effect?
That actually sounds familiar. I wouldn't be able to describe it, but
yeah. So
I feel like that.
I'm being like super nerdy and pretentious bringing up the name right now, but it was something someone had said and explained, and I looked it up, and it's where people who have very little information and knowledge or very little experience feel like they know a ton. And then someone with a lot of experience and knowledge feels like they don't know very much. So it's almost like the inexperienced people overestimate their abilities and experienced people underestimate their abilities. So you think about like someone in your graduating class who was a know-it-all. I'm sure you can picture at least one of them. As soon as they got into practice, they were like using terms like the Dunning-Kruger effect and things like that. So, and these are the people who like do their own research, and like I saw it on Instagram, or you know what I mean, I read this, or now I'm going to make this big change. And it's like, okay, you don't have a lot of information and you seem really sure about this for some reason. I don't get it. And then for those of us, like the more you read and the more you see patients and the more you learn, for some of us, it's like, man, I feel like I know less. I'm less confident now about a lot of things than I was when I graduated grad school. Just because the more you learn, the more you're like, I don't know anything. And but I think that's been one of the most therapeutic and rewarding and I guess things for me stepping out into my own practice and doing my own thing is being able to tell patients like, I have no idea. Like, I don't know. But we can figure it out. If you stay here long enough, I will figure it out. Because if we have a plan, you got 3 options. Either you're going to get better, we're going to see those changes, in which case we're just going to keep going in that direction. The other option is that we don't see any changes. Nothing happens. Well, that's information. Maybe the dose is too low. Maybe we got to tweak something. We have to make a calculated change and see. The third option is you get worse, which patients hate, but I love it because it's like, well, we're just going to do the opposite of that then. You know what I mean? Like, that's a ton of information. So any plan that you have, you only have 3 options, and you're going to learn from all of them. So sometimes, like if a patient was like, and I've said this to people actually a couple times where it's like, oh, I've got chronic pain, and so this woe is me, and it's like, do you think you can figure it out? And like, I can almost guarantee you I can figure it out if you hang out with me enough. Like if you stick around long enough, because let's say you are 99 failures away from the solution. Like, let's say we knew that. We're going to have to fail 99 of our plans are going to have to fail to get you what you want. And somehow we knew that. Well, let's fail as quickly as possible. You know what I mean? Like, let's knock these things out. Let's just start crossing stuff off the list. So I think a lot of times people think about failure in care and failure in treatment as like a setback. It's not. You know, it depends on how you look at it. It's information, and it can propel you forward. It is that way in a lot of other things, like in engineering and building anything. Like, the idea, if you're going to design something new, is to get a prototype out and watch it fail, and then see how it failed, and then make a new prototype. You've seen The Incredibles, right?
Oh, yeah.
Yeah, so like The Incredibles, the first one, that's literally what he did when he was making that spherical robot that was going to take down all the superheroes, is he made a prototype, and then he went out and basically convinced an old superhero to come fight it. And then it killed the superhero, but he saw how it failed, and then he just kept adapting it. And then they showed you all the different prototypes and how they changed after the superheroes had fought it. And then Mr. Incredible was the first one to actually defeat it. So he had to go back and like completely rework it. But he had to, that mad scientist, the supervillain, had to fail a bunch of times. And because he was a scientist and an inventor, he was aware that was the inevitable. He actually went out seeking failure so that he could find the best path. I think the problem with healthcare and with people who are in pain is like, well, I don't want to hang out in pain for longer than I have to. But if you're in chronic pain, what's the difference? You've been like this for the last 10 years anyway. What do you care about another 10 months? You know what I mean? Like, because the alternative, like if we do nothing, what do you think the chances are that you're going to get better? 0. So you come hang out with me within the next 6 months, we're probably going to figure it out. I might not be your healthcare provider by then because I may have passed you on to someone else, but we're gonna fail epically as many times as we can and cross as much stuff off the list so that we can get you closer to what you wanted, the goal that you want. None of that involves me doing stuff to you. It involves you being essentially Mr. Incredible fighting this robot, and then me just watching and being like, okay, well, now let's make this change. Let's make this change. And then you giving me that feedback, and then we just kind of move in that direction. I'm kind of proud of myself because I just made up that analogy right now. I never thought about that before, but that was just what popped into my head. But yeah.
Did you just watch it last night? Or
No, I just have it on replay in my head. But anyway, I think it's maybe a good spot, a good place to end this one, because I think we can go on forever and just go in our own circles. But I respect every other healthcare provider and wherever you are with this. And for patients out there who are like, sounds like blasphemy. This is the exact opposite of what my healthcare provider tells me. What do I know? Just listen to, if you have a good relationship and you think going in and getting your back cracked every week is the appropriate way to deal with your chronic pain, who am I to tell you that it's not? But for those people out there who feel lost and feel like they've slipped through the cracks and they want something better and they feel like they need something better and they don't know where to turn to, I think you need a healthcare provider who's willing to say, I don't know. I think you need a healthcare provider who's willing to admit that they don't have a plan, but they've got a process that can help you work through it. and someone who's not going to steal the opportunity so that they can slam dunk it and say that, because I feel like that's how it is. It's like, oh, I was in so much pain. And then to be honest, like when you learn how to adjust people, how awesome does it feel when someone's in pain and you just do this epic side roll and their whole back ripples and they get up off the table and they feel better. You feel like a superhero. You feel like you're a magician, like you've just done something incredible, and they give you a hug and like you just feel so awesome. Well, that's all about you as a provider. You know what I mean? Like I think it's a cool skill to have, and we can use it sparingly, but I think it's a very juvenile way to look at it, and I realize that's a little inflammatory because there are a lot of providers, especially a lot of chiropractors, who've been in practice for 20 years and they get off on that every day. You know what I mean? They go to work just to deliver the crack. And so they can be the superhero. And I just feel like, I don't know. If you want to practice that way, I guess. I don't. And if you're a patient and you want to receive that type of care, I guess, I wouldn't. So for people out there who are like, I don't want to receive that kind of care, I've done that, I need something better. There are things that are better. And unfortunately, or fortunately for a lot of you, there are cash-based providers out there who, will look at things differently, and try different things. And I don't know, if you're interested in working with me, I don't know. I don't know a lot, but we can definitely figure it out. And I love the idea of overwhelming a problem with an excellent solution. I wish I had come up with that, but it's a process, and it's a process of, unfortunately, the person in pain kind of staying in pain for a little bit and working through this stuff, but working through it systematically. And we're making these changes, because what if it was something, I've never had this happen, but I have heard that this has happened where people, it's like someone's got like chronic knee pain and they do like some very specific dietary changes, and within a couple weeks the pain's gone, and they've tried everything else, you know what I mean? And it's like, oh, I just needed to eat less sugar, or something simple like that. Or like, oh, I have low back pain. And then I started walking. I went from 4,000 steps a day to 10,000 steps a day, and my back pain is significantly better. How could it be that simple? And so what if, for someone who's listening right now who has chronic pain and feels lost, what if it is that simple? Just no one's systematically gone through. Every time you go to a healthcare provider, they steal the opportunity for you to get better. They take away your pain. They make you feel better. They make you feel dependent on them. And there's no systematic process for like evaluating why you're in pain. What is the request for change, or what are the requests, and how do we prioritize them? And then can we just start checking things off the list? And so I feel like that process is really valuable. And I don't know. That's where I am with that, I guess. So like I said, this was supposed to be a solo episode of just me ranting and thinking out loud, but you were in town, so
Doubt.
Yeah. Any closing thoughts?
I don't think so. I think it is an interesting way to look at it. I think that's the side of healthcare and just care in general that isn't looked at as it's definitely not something that's discussed as often as the other way. So I do think it's an interesting way to look at it. So, but I can also see how you go back and forth. I understand the going in a 360 one side versus the other. So
sometimes I wish it was just as easy as just cracking backs. I'm just like, in a weird way, like, oh, maybe there's just a body of evidence that's about to break, where it's like, oh, spines really are out of alignment and we can just crack people's backs and fix everything. That would make my life so easy. You know what I mean? Because I could have some faith and some confidence in it, and actually some enjoyment out of providing a simple therapy that just fixes everything. It just doesn't, It's like supplements. people are like, yeah, I take all these supplements. And it's like, why don't you take vitamin push-up? You know what I mean? Like, it's going to be better and it's free. You can take it as much as you want. And when you take it enough, not only does it decrease your risk for all the bad stuff, but you look better at the beach. So I don't know.
Or the sledding hill.
Yeah, I don't know. I don't know what supplement is going to do that for you. But yeah, I don't know. Supplements are another topic, but I don't want to go down
next time I'm in town.
Yeah. It's another topic that I'm not very positive on. I think people who listen to the podcast know that. Although if someone's listening who's like really pro supplement, I would love to have them on if they can defend it. So
yeah,
I don't know.
I'd tune in.
Yeah.